Hello, can everybody hear me back there? I'm not sure I can see you all, so yeah, I think the mic is working. Good. So thank you for your patience, and I apologize for the delay in the start of the program tonight. I'm Sherry Mizumori, the Chair of Psychology here at the University of Washington, and I really have the great honor of welcoming you to the first of many lectures in our 2023 Edwards Public Lecture Series. And as you know, the topic for this particular series is has to do with the transactional relationship between mental health research and care. Now, before I introduce the speakers for this evening, I just want to give you a little bit of background on the Edwards Public Lecture Series, just in case you're not so familiar with it. Now, Professor Alan Edwards was a faculty member in our department in psychology, and he was here for half a century, from his arrival in Seattle in 1944 to the time that he passed in 1994. And so he had established his Edwards Lectureship because he thought it was so important to bring in people from all over the world to the University of Washington, to the psychology department, so that we can have really stimulating, active, and fun conversations with the faculty as well as with students. Now, as I mentioned, this year's focus will be on the mental health research and care. And in particular, tonight's is the first set of two sets. So next week we'll have another set of two speakers. And this, for tonight, the topic is, as mentioned here at the top right here, it has to do with it, from the lab to the clinic and then back to you. Personalizing mental health service and practice. Now, you know that the challenges of the global COVID-19 pandemic has demonstrated the urgent need for expanding the mental health workforce and also for investing in mental health research and interventions. And so our two speakers tonight will, along with the two more next week, will present two different frameworks for approaching this problem of understanding and treating mental health challenges. Now, our first speaker is Dr. Angela Fang, who is an assistant professor here at the University of Washington Psychology Department. Now, unfortunately, due to a health condition that arose last night, she's not able to be here in person, but she has graciously agreed to be live Zooming her talk to you. And so if you have questions, we will still be able to ask questions, and she will be able to still respond. Okay. So now let me just give you a brief introduction to Dr. Fang. Now, she received her bachelor's degree in psychological and brain sciences from Dartmouth College, and her PhD is in clinical psychology from Boston University. After completing her predoctoral clinical internship and postdoctoral fellowship at Massachusetts General Hospital and Harvard Medical School, she continued on as a faculty and a licensed clinical psychologist in the Department of Psychiatry's OCD and Related Disorders program. Now, she recently established a center and is now director of the Center of Neuroscience, Neuroendocrinology, and Clinical Translation, which she calls the Connect Lab, which you will be hearing about. And here she is focused on understanding the brain and psychological mechanisms underlying social and emotional processing in anxiety and obsessive compulsive disorders using an array of different methods, including neuroimaging, neuroendocrine assays, pharmacology, and behavioral and self-report assessments. And in particular, she's interested in an aspect of social cognition, such as attention, social threat, and self-focused attention. And what she wants to understand what goes awry in different psychiatric disorders, and then translates this knowledge of neuroscience and psychology to inform the clinical practice and clinical interventions. And so with that, what I'd like to do now is turn it over to Dr. Fang, who I believe will appear on the screen. Now, there she is.
Hi all, I hope you can hear me okay. This is absolutely mind-boggling that I'm not there in person. We've been planning this for months. And so I'm just so sorry that I can't be there with you in person. I really thought about, giving this talk behind a wall, right next door so that I could be closer. But I came to the Edwards talk for the first time last year after I had closed down during quarantine. I was just so excited by the buzz around it and getting everyone in the community out. So I'm just so sad that I can't be there. But I haven't cut out any of the fun parts of the talk. So there's some engagement involved. I hope you can still humor me. in those parts of the talk, and I hope we have some fun. So I'll be talking with you today about the promise of integrating neuroscience into treatments for anxiety. But I wanted to start off this talk to share just a little bit more about me. So give you a little bit of context for how it started and how it's currently going. So my family and I moved from Taiwan, where I was born, to New York in the late 80s. And you can see the Twin Towers are still standing in New York at the time. We were really struggling to just kind of survive day to day and learn the language. And we didn't have any language for mental health. I would say growing up in this way, though, did make me very attuned to the ways in which our social context and our culture impacts our beliefs and our behaviors. And so it'd be really hard to imagine if you were to tell this girl 30 years later, 30 plus years later, that she would be running a research lab on mental health. I wouldn't have even been on my radar. Fast forward to today, where I have two kids of my own, I think about their social context and their culture and their mental health all the time. It's even harder to imagine that I would be here talking with you all about integrating neuroscience into treatments for anxiety, because in Chinese, the word for psychology is xingli shui, which is a study of what's within the heart and not necessarily what's in the brain. So even harder to imagine how I got here today where my interest in neuroscience came from. So my journey began in New York. This is the Throgs Neck Bridge that connects New York City with Long Island, where I grew up. And again, I didn't have anyone in my family who were scientists or researchers. We didn't know what clinical psychology was. I was the first in my family to get a PhD. It was really until I went to college and started working on an inpatient unit at the local hospital that I became really interested in this whole world of mental illness that I hadn't known about. So I got my PhD in clinical psychology at Boston University in Boston, and became immersed in work that was trying to augment exposure therapy for social anxiety disorder. A lot of Dr. Guastella's work is seminal in this area and really inspired my dissertation, actually. So I became really interested in oxytocin at this time and other pharmacologic agents, what we call cognitive enhancers, that can improve or enhance certain types of learning processes during therapy, and always for anxiety and related disorders. Fast forward now to Seattle, we moved in 2020 during the pandemic, and it has just been such a joy to have kind of my dream job in working with such talented individuals from really diverse training backgrounds and diverse backgrounds themselves, all dedicated to understanding mechanisms underlying anxiety-related disorders. That the little one maybe doesn't count quite as much, but he's working on it. So we established the Connect Lab, the Center of Neuroscience, Neuroendocrinology, and Clinical Translation, because the idea is to translate and bridge together lots of different disciplines that don't normally talk with one another to try to actually translate into clinical applications. We've been interested in understanding how people interpret and process information from their social environments, and how that's instantiated in the brain, in their physiology, and in their behavior. At the end of the day, I'm a clinical psychologist. So it's about integrating all of these kinds of information to inform and guide clinical decision-making. So we're all here because we're interested in the global impact of mental disorders. Data from the Institute for Health Metrics and Evaluation, which is right here down the street in the Population Health Building, which is very exciting, has shown that 1 in 10 people globally live with a mental health disorder. So that means each of us either have experienced a mental health disorder ourselves or know someone who has. Anxiety disorders are actually the most prevalent class of mental disorders globally, contrary to what people might believe. And here in the dark green in the US, we're a country with one of the highest rates of anxiety disorders globally. depressive and anxiety disorders are the leading causes of not only mental health related burden, but any health related burden globally. So what's being plotted here are the disability adjusted life years, which is a rough metric that approximates mental health burden. And you can see in the red and the red shaded areas, depressive and anxiety disorders are most impacting younger people and females. And this is troubling just because we know that being younger and being female is associated with a greater perceived need for treatment. So that was the picture before the pandemic hit. Now, since 2020, it's been estimated that major depression and anxiety disorders increased approximately 25% globally. And in the US, that rate, it ranges somewhere between 29 to 35%. So it's very clear that COVID just exacerbated existing prevalence rates. And recognizing that growing prevalence, for the first time ever, the US Preventive Services Task Force recommended screening for anxiety, different from screening for depression, in children as young as 8 and adults up to 65 years old. So we're here to talk about personalizing mental health science and practice. So let's talk about a personal case of Mary. She's a typical patient with social anxiety disorder. She's a single woman in her mid-20s. She comes into the clinic with comorbid depression, and she's been prescribed Xanax, which is a common benzodiazepine for treating acute anxiety levels from her primary care doctor. Her main challenges are having trouble speaking up at work, talking to people on the phone, meeting new people. And like many people with social anxiety disorder, she has not sought treatment for 14 years since her symptom onset. So there's a really long time of delay between symptom onset and treatment-seeking behavior. So she's asking herself, now that she's thinking she should get treatment, she's thinking, what kind of therapy should I seek out? And should I try medication first? She's wondering, where can I find accurate information about my symptoms and my treatment? So I'm going to talk today about how I think neuroscience can help in these areas, help us understand how treatments work. And not only that, but how we can help Mary find a treatment that is likely to be successful for her so that she doesn't have to do this trial and error business. We're also going to be talking about how neuroscience can help with identifying novel drug targets and developing more drug therapies, because having these additional clinical tools are so useful for people who are responding to first-line interventions. And also how neuroscience can help from the perspective of education, both for patients and providers alike. So starting with how treatments work, do we even know whether our treatments work? Yes, so the answer for anxiety disorders and depression is very clear that cognitive behavior therapy is a first-line psychological treatment for these disorders. A recent meta-analysis, semi-recent from 2016, in 144 randomized controlled trials showed strong effect sizes for social anxiety disorder, panic disorder, and generalized anxiety disorder. Anything here above 0.8 is considered a strong effect size. So CBT really works. And yet, in another meta-analysis done on 52 trials of CBT, showed that in all of these trials, on average, 52.1% of these individuals in the studies were not meeting remission criteria. What do we even mean by remission here? You would think there's a standardized definition, but actually there's many different ways to define and quantify it. Most studies use either no longer meeting diagnostic criteria for the primary disorder, or achieving some sort of good end state functioning that's outside of their symptoms, specifically for the primary disorder, or a combination of the two. But most of these studies, if you just collapse across all of these studies in this meta-analysis, most people are still not meeting full remission criteria. So what do we make of this huge gap that we have? On the one hand, really important and helpful treatments like CBT, and yet they're not helpful for everybody. I would say that one reason for this is that our current classification system that's based on the Diagnostic and Statistical Manual is one explanation for this. It kind of treats disorders as separate, distinct entities when we know like people like Mary are coming into the clinic with lots of co-occurring comorbidity disorders. So let's say for Mary here, if she were the sample subject and the pink part is the social anxiety disorder and the blue is the major depression. And let's say she has some subthreshold panic symptoms and she's got some panic disorder in green. The DSM kind of treats these disorders like they're distinct, when actually these disorders co-occur quite a bit. And it would be much more meaningful to identify clusters of symptoms or dimensions that cut across disorders that match onto Mary's profile much more meaningfully than the category label of depression or social anxiety or panic disorder. Maybe these transdiagnostic dimensions would actually say something about the underlying causes of the illness and not just based on what you see clinically symptom-wise. So you might be wondering what's an example of one of these transdiagnostic dimensions that cut across multiple disorders. I would say self-focused attention is one of those dimensions. Self-focused attention is a cognitive bias to be really excessively focused on internal thoughts, feelings, beliefs, and physical states. So it's kind of like rumination because you're thinking a lot about past events. It's kind of like worry in the sense of thinking about future events or future plans, but it's always focused on the self. So for Mary, her self-focused thoughts could be something like, what does my boss think about me? How do I look? Did I make a good impression to my coworker? I'm feeling so anxious and sweaty in my hands. And what are some ways that we can measure self-focused attention? So the traditional way in clinical psychology is using simple paper pencil questionnaires. So one questionnaire I've used is the public self-consciousness scale, developed by Shire and Carver, and originally by Dr. Fenigstein, who I think is zooming in tonight as well. This is a measure that has 7 items that tap into people's self-consciousness in terms of how they're being observed by others. And this really maps onto self-focused attention because these patients who have high SFA, they see themselves like a social object when they have any social interaction. They kind of take on an observer point of view and start wondering, well, how do I look from that observer point of view? And so look at these items. I'm concerned about my style of doing things. I care a lot about how I present myself to others. I'm self-conscious about the way I look. I usually worry about making a good impression. Before I leave the house, I check how I look. I'm concerned about what other people think of me, and I'm usually aware of my appearance. For the disorders that I've been interested in, such as social anxiety disorder and body dysmorphic disorder, which is a condition where you're really focused on perceived flaws in your appearance, these items just tap so well into those pathologies. So we can use this measure to measure self-focused attention. I'd like to also show you a task that we might use in the lab where we measure response times as another way to measure self-focused attention. So let's do this task together. If you see a self trial on the screen, you can say out loud, does this adjective describe you, yes or no? If you see an Obama trial, you can say, does this adjective describe former US President Barack Obama, yes or no? And if you see an uppercase trial, you can say, is this adjective printed in uppercase letters, yes or no? All right, are you ready? I can't see you, so I'm just going to assume you're speaking this out loud and that you're sharing your answers out loud. Okay, so that was a few trials. It actually doesn't matter at all whether you said yes or no. There's no real correct answer here. So you might have seen some discrepancies if you actually were saying this out loud in the room between the people sitting next to you. But it actually doesn't matter. What we're interested in is how long it took you to respond to each of these trials. And we picked Obama only because a lot of these studies have used past presidents. So it allows us to compare with past research. And so if you look at response times, what we find in our patients with social anxiety disorder and BDD, this is a transdiagnostic sample in this patient group, which is a little bit different than how a lot of clinical psychology studies are designed, where they just take one case group and one control group and compare them against each other. This is a transdiagnostic group that was selected to have high levels of self-focused attention, and the control group had no psychiatric disorders and were selected to have low levels of self-focused attention. So we see that the controls had no difference responding to self or other trials, whereas the patients spent a much longer time on the self trials compared to other. And the idea here is they're potentially engaging in some sort of additional self-focused processing when they're responding to those self trials. So that's a behavioral way to assess self-focused attention. I've talked about a self-report way to measure it. We're here to talk also about neuroscience, about the brain, right? And we know from Jerry Maguire, which is a movie I grew up watching, that the human head weighs 8 pounds. But did you also know that the brain uses 20% of oxygen consumed by our bodies, which is a really disproportionate amount of energy compared to its mass? And did you also know that during active tasks, so if you're like my son who's glued to his iPad, when you're engaged in active tasks, the brain's energy metabolism actually only goes up by 5 to 10%. So what this means is that your brains are working so much harder at rest than it is to engage in some focused task. So what is happening at rest? It's possible your brains are never truly at rest. So let's try this out. This is maybe something you would do in the scanner if you were to participate in one of our studies where we would just collect resting state data. So let's have you close your eyes for 20 seconds and engage in this type of undirected thinking and just kind of let your minds wander. Just don't fall asleep. Okay, I hope that was enough time. What did you think about? So raise your hand if you thought about past memories. Raise your hand if you thought about future plans. And raise your hand if you thought about any other personal experiences. Well, it turns out that if you're like other participants who do this task and they're engaging in unconstrained, spontaneous cognition, they think about themselves. And what's also interesting is that there's a set of brain regions that are reliably activated when you engage in this task called the default mode network. And I like to talk about the default mode network a lot in comparison to other canonical resting state networks in the brain, because there's some inherent interaction between these networks. So the default mode network is in general turned off when the somatomotor or the dorsal attention or the executive control, auditory, visual networks are turned on. So in particular, the dorsal attention network is activated when your brains are engaged in some external focused task, external goal-directed activity. And the default mode network is turned on only when you're engaged in internal processing. So there's an inherent interaction between these two networks. And you can think of the default mode network then kind of like a Windows screensaver. I personally use Mac, but I found a Windows screensaver here. And it's kind of this idea that it only comes on when your computer or your brain is idle, right? And once you're ready to engage in some sort of task, like say in Microsoft Office, it turns off. So then your default mode network would turn off and your dorsal attention network would come online. It's a little bit of an overly simplistic way of describing it, but there's this general turn on and off dynamic between these two networks. And that's in healthy brains. So indeed, what we find is that self-focused attention is linked to abnormal connectivity between regions of the default mode network and the dorsal attention network. So these are these two networks involved in maybe external attention and internal attention. And this different pattern of functional connectivity correlated significantly with self-focused attention that was self-reported, not with self-reported rumination or symptom severity. So these are functional connectivity maps that are unthresholded that differ between controls and patients. And you can see here how the patterns differ between controls and patients. I've kind of highlighted them in arrows. And the specific region of the default mode network is the posterior cingulate cortex, the PCC, and the specific region of the dorsal attention network that was shown to be different between groups is the superior parietal lobule, so we'll call that the SPL. So what we found in our study, which is really interesting, is that when you just take self-report and behavioral measures of SFA, like the ones I showed you, that only accounts for a measly 1.7% of variance in eventual symptom reduction when patients undergo 12 weeks of CBT. Can you guess what they achieve once you add in the resting state marker of self-focused attention that I mentioned to you? It actually accounts for 32.3% of the variance in symptom reduction after CBT. So these are two separate prediction models that we're developing to understand what's going to help us best predict for someone like Mary whether she will respond to CBT. And adding in these neural measures gives us such more sensitive information about whether she will respond to CBT. So like my mentor and colleague, Jamie Fuster, would say, it's like using a fingerprint to identify somebody, or using a height to identify somebody when you could be using their fingerprint. There's so much more higher data dimensionality in fMRI data and imaging data that we're not tapping into routinely in clinical practice. And there's something really important that it can tell us about someone's eventual treatment response. So when you look at in the whole brain, what regions are associated or connected to the PCC, this is the part of the default mode network we've been looking at, that's associated with symptom reduction after 12 weeks of CBT, we of course find the PCC and SPL connectivity again. That's showing a significant prediction here for eventual symptom reduction. So for somebody like Mary, let's say she's this blue dot, because remember we had people with BDD and social anxiety. The social anxiety were blue dots and the red dots were BDD. So let's say Mary is this social anxiety patient in this blue dot here. Her connectivity value at pre-treatment is -0.2. She would have been predicted based on this model to only achieve 30% symptom reduction. So you probably would have thought, she's really not going to be a major responder to CBT. Maybe we should consider another treatment. But interestingly, if you look at changes in connectivity over the course of the 12 weeks, so that's what I'm showing you here are the individual patient trajectories in this connectivity between the PCC and SPL, which are proxies for this connectivity between these two brain networks. You see that overall, people who are responding in blue, this is the grand mean that's being shown in blue, this thick blue bolded line, those individuals are seeing more negative connectivity over the course of treatment. So those networks are becoming more anti-correlated, as opposed to the red, the grand mean for the red is reflecting here the non-responders, people who are not achieving at least 60% symptom reduction after CBT. And Mary, sure enough, is showing that pattern of a responder. She's actually showing more negative connectivity over the course of treatment, suggesting that she's learning to maybe toggle between these two attention-related networks in a meaningful way. So what this is all trying to say is that if we were to just use pre-treatment information alone, we would have maybe told her not to try CBT. But if we look at changes in her connectivity over time, we would have seen that she actually could respond. She can actually shift her brain networks appropriately to eventually fully respond to CBT. So what I'm hoping to convey here is the value of not only a single time point of an imaging scan at pre-treatment, but using it multiple times throughout the course of treatment to help us guide, are the brain networks shifting in the right way to guide our clinical decision making. And maybe if it's not shifting in the right way for Mary, then we know we should refer her to something else that can shore up more attention resources before she engages fully back into CBT. This makes a lot of sense theoretically because CBT is a treatment that is very cognitively demanding and takes a lot of attention. And we expect our patients to be able to challenge their thoughts and monitor their symptoms. And not everyone has those capacities just ready to go at pre-treatment. So I think the brain, this work can really help us reveal some mechanisms that we otherwise would not be able to see using self-report measures. So our next steps are to compare brain profiles of treatment responders and non-responders. We can also integrate machine learning to accommodate multiple features and make predictions of treatment response on an individual basis. And then also combine with large data sets using neuroimaging consortia, which is already underway in order to extend the generalizability of these prediction models. And here is a little nod to the Center for Human Neuroscience, the 3T Siemens Prisma scanner that we scan on, which is the most beautiful machine ever. It's a really souped up imaging center if any of you ever have a chance to go down to visit it. Okay, we're going to talk now a little bit about ways that neuroscience can help us harness better drug discovery. So remember, Mary was wondering maybe she should try out medication first. And this is a really valid question because some patients are really, maybe she heard about CBT involving approaching her feared situations and not wanting to do that. And maybe the idea of medication just sounds more appealing to her. So I thought this was an interesting study because it's a general commonly held belief that CBT is a really effective intervention, both in the acute term and in the long term. But with drugs, they kind of lose their efficacy once you discontinue them. So this study this was a meta-analysis of follow-up studies that tried to disentangle whether there was any benefit to continued benefit of CBT and drug medication for anxiety-related disorders after they discontinue them. And what they found is that there is this not only maintenance of gains for CBT, but almost a slight further improvements in CBT in the follow-up period. And with drugs, they maintained their efficacy over time too, which is all just to say that both CBT and medications, especially a class of medications called SSRIs, are very effective for anxiety disorders in the short term and in the long term. I think these are really difficult studies to do because, of course, people might drop out of the follow-up phase because they're doing worse. And it's very hard to account for that kind of attrition. It's also hard to know whether people start engaging in other alternative treatments in the follow-up phase. But in general, this is, I think, promising evidence that's starting to emerge that, there are some enduring gains for both CBT and meds. But what we also know is that patient preference matters. So I wanted to highlight some of the work from colleagues in our department, Dr. Laurie Zollner and Dr. Peter Royburn in UW Medicine. They conducted a preference trial of 200 patients with PTSD. And they found that if they matched the patients to the treatments that they wanted, in this case, it was either medication with sertraline, which is an SSRI, or with CBT protocol, which is prolonged exposure therapy, a behavioral intervention in this case. If they matched them to one of these treatments that they wanted, those individuals were much more likely to see better response rates and see no longer meeting diagnostic criteria by the end of the trial. They also found that patient preference was linked to treatment adherence during the treatment and also better cost effectiveness. So it actually really matters what Mary wants as far as a treatment. And this is where I became really interested in oxytocin too, just because when first-line interventions don't work, as a clinician, all you want is to just have more options for your patients. So I mentioned in graduate school, I became really interested in oxytocin. The side effect profile for oxytocin is just much better than other drugs used for psychiatric disorders. It's an endogenous neuropeptide. Men and women already produce it in our bodies. It's naturally released during labor and is used as Pitocin, as if anyone has gotten a shot of Pitocin to induce uterine contractions during labor. It's been dubbed in the news as the love drug, the cuddle hormone. But we've been really piggybacking off of some advancements recently to deliver oxytocin intranasally, which is thought to cross the blood-brain barrier and go right into central targets. Oxytocin is produced in these specialized cells of the hypothalamus and acts both as a hormone. It acts on these peripheral organs and muscles, as well as a neurotransmitter in the brain. So it's a really special type of neuropeptide. What Daniel Quintana, who also trained with Dr. Quintana, has been showing in his work is how there's some really important translational assumptions that need to be met in order to translate these this work clinically. So for example, it's not very clear to us what the mechanism is for how oxytocin actually reaches the brain and whether it reaches those central targets. The best evidence we have right now is from animal work, but nothing in humans because it's very difficult to tap into cerebral spinal fluid in humans unless they're engaging in some sort of neurosurgery. So one major, he calls this auxiliary assumption that needs to be met before this is translated clinically is to determine how oxytocin reaches the brain and whether those targets are actually reached. The general idea here, though, is that oxytocin can enhance social cognition. It can maybe mediate social approach behavior. There's lots of differing theories right now about oxytocin's mechanism of action. But one task that's commonly used for oxytocin work is the reading the mind and the eyes task, which is actually a very difficult task to do. It's been studied really well in autism populations, which Dr. Guastella has lots of experience with. But if you try doing this task with me just for a few trials, see if you can get some of the answers right. So what is this eye region displaying? So this one is playful. What about this one? This one is upset. And this one is desire. So very difficult. It's a test of complex emotion recognition. We thought that people with BDD would show deficient levels on this task, and they ended up doing totally fine. We also thought that their basal oxytocin levels, this is based on a resting, fasting blood draw over the course of 1 hour. We took their blood samples every 5 minutes. We found that their serum levels were actually higher for oxytocin compared to controls, which is also not what we expected. And the idea here is, what was also interesting is that the oxytocin levels were correlated with their symptom severity. So if you were more severe, you had even higher levels of oxytocin. So we didn't have any data to substantiate these speculations, but we speculate that what's happening is that oxytocin is being produced in excess in order to help patients re-engage in social situations because people with BDD are so concerned about their appearance that they just withdraw socially. The other idea is that maybe people with BDD are just so chronically stressed and anxious, and we know that oxytocin could be produced in response to that stress. So this was me doing some bench work, which we never get to do as clinical psychologists. And I was pooling the samples from all of the blood draws together into a mean pooled sample of oxytocin, which is very fun. We also are interested in applying oxytocin in an extinction learning context. Cognitive behavior therapy is thought to rely partially on extinction learning. So the general idea here is that if you were to teach a mouse that this certain context is associated with shocks, if you put them in that context, they will express fear. They will show a fear response. But if they continue to stay in that context in the absence of the fear, of the shocks, you would see a reduction in that fear response. And that's exactly what we hope to do with our patients when they are undergoing extinction learning, is to approach that context or that situation, that setting that is evoking fear, and learn that it's no longer dangerous. There should be no shocks associated with those situations, and they'll eventually learn to not fear that situation. So if you were to be somebody really afraid of giving a public speaking presentation and you've learned that you've had a horrible experience with that, that's essentially your training opportunity there, your training experience to pair those two things together. So if you continue to give those talks, you'll be deathly afraid of giving those talks because you have that learning history. But if you continue to approach those situations in the absence of that shock or that fear, and you learn safety, eventually the idea with extinction learning is that you learn that this is actually a safe situation. And yet a lot of our patients are very averse to doing that type of exposure therapy. It's just not fun to think about approaching your fearful situations directly. So one thought we had was, can we just learn safety from watching someone else learn safety? We know that social fear is acquired from watching other people acquire fear. How much have you watched a scary movie and started to become scared of something just from watching a movie, and someone else in the movie getting scared by something and not you directly becoming scared by it? Parents model fear all the time for their kids, or they can model safety learning for their kids as well. And so here we wanted to see what would happen if we gave people oxytocin and had them learn safety from someone else undergoing extinction learning. There's already a really nice translational pathway for this, because therapists model this all the time in therapy. They might, for example, model giving a public speaking presentation or touch a dirty toilet and show patients that we're safe. It's actually not dangerous and we're safe. And that alone can actually help patients feel maybe more motivated or more engaged in doing the exposure. So we're wondering here whether oxytocin can enhance social safety learning. And that's a currently undergoing study in our lab. So finally, I just want to say a few words about education and how I think neuroscience can help us in this area. Mary was really wondering where she can find accurate information about her symptoms and her treatment. So what we're talking about here is mental health literacy and neuroliteracy, specifically the knowledge about disorders that can help with their recognition, their management, and their prevention. And this is particularly important to pay attention to because mental health literacy is associated with service utilization. So people with low literacy have been shown to be less likely to seek out treatment. And what's really tough about the neuroscience literature is that it's not accessible to people. There's a lot of jargon, a lot of brain regions. But so I'm going to share with you some of our work and how we've tried to make this much more digestible. But part of this neuroliteracy is understanding what is a representative brain, that brains don't occur in isolation at a cellular level or an individual level. They change over the course of development over time. They exist in a larger community context, a larger personal and cultural, social context. And our brains are constantly responding to environmental stimuli. It's constantly changing based on things that you're learning. So I think it's a very powerful message for clinicians and for patients to know that their symptoms are not static, they're not permanent, and they're changeable. We've been working on a webinar series since the pandemic launched. I just stepped off as chair of the special interest group, the NTTR special interest group, that was highlighting the work of neuroscientists worldwide and talking with them about why is this neuroscience work not penetrating actual clinics? What are the translational barriers there? And we approached this question, this problem, from the perspective of translational readiness, from rigor and reliability, and also from a bioethics perspective. And so I encourage you to check out that webinar repository that we have on the NTTR website. We also held a Shark Tank workshop for clinical psychology trainees who don't typically have training in neuroscience. Same thing for psychiatry residents, actually. It's been very surprising for me to learn that this is just not a core part of their curriculum. And so we held it was really a Nurse Shark Tank workshop. Nurse Sharks are actually more friendly. And the idea was to pitch a project that had the potential to penetrate psychology clinics and to talk with dissemination scientists and other neuroscientists to talk about how to enhance that application at the outset of the work. So yeah, a very fun workshop. This is just a screenshot of our website, just highlighting the articles that we've digested and curated specifically for clinicians who want to learn about the mechanisms of different symptoms and disorders. And importantly, the studies that have shown the brain regions and the connectivity patterns that can change over the course of treatment, showing that sense of malleability for patients. And sure enough, a meta-analysis recently came out showing that there are changes in limbic and frontal regions after successful psychotherapy for anxiety disorders. And again, an important message, I think, to send to patients. So the promise of neuroscience is that it can be used to inform clinical decision-making about treatment selection. And I would say not even just about treatment selection, but about ongoing treatment planning. Neuroscience opens the door for treatment options that would otherwise not be available for those not responding to first-line interventions. And that's the importance of developing these additional clinical tools like with oxytocin. Neuroscience can also enrich our understanding of our behavior change efforts and gives both clinicians and patients a sense of empowerment and maybe a sense of agency and control over their behavior in a way that they otherwise wouldn't. So to answer for Mary and come full circle here, I would tell her that CBT or medications are both effective. Go with what you want to do, what you would like to try. Don't suffer alone. Try to share your concerns with others and rely on your support system. And just know that your brain is very malleable.
To do Q&A later, maybe. Okay. As a cliffhanger, yeah? But I think she was about to wrap up. And again, because obviously we had some technical difficulties, but what we're going to do is now go to our second speaker. We're going to try and get Angela back so that then she can join a general Q&A after the next speaker has given his talk. So if you had questions, write them down, hold them in your memory, and then we'll come back to those questions later. Okay, with that, then, what I'd like to do is now introduce our guest speaker, Dr. Adam Guastella, who's a professor and also the Michael Crouch Chair in Child and Youth Mental Health at the Faculty of Medicine and Health in the University of Sydney in Australia. Now, his position is based both in the Sydney's Children's Hospital at Westmead and the Brain and Mind Centre at the University of Sydney. And what's interesting about his work is really, I think, quite different because his work aims to build collaborations and partnerships between researchers, clinicians, and services to ensure that children and families receive the best available assessments and treatments to support their mental well-being. And as part of this role, he's also the co-lead of the Child Neurodevelopment and Mental Health team at the University of Sydney. And this team aims to solve complex problems for children with especially neurodevelopmental disorders, and also for their families and on the problems that it creates for the families. And he uses a team of multidisciplinary professionals, professors across the university. Now, he is also the co-lead for what's called the Child Bioinformatics Hub at the University of Sydney, and this uses technology to support the well-being and research with the families. And so Dr. Guastella has obviously a very impressive track record in human translational neuroscience that I think you're going to be hearing about tonight. Now, as similar to what Dr. Fang had described, his primary interest is in using neuroscience to inform and develop novel treatments for young patients with mental health problems. And that this research has really led him to study the neurobiology of even basic social behaviors, its development in early life, and how this neurobiology relates to symptoms that ultimately cause distress and impairment. And so with that, I'd like to introduce Dr. Adam Guastella. Just advance.
Yeah, okay. Thanks, Sherry. Look, thank you very, very much for the invitation to present here. Commiserations, but what a wonderful talk from Dr. Fang. And it's a real shame she couldn't be with us here tonight. Dr. Fang is a wonderful example of the new breed of neuroscientists that are using neuroscience to transform and to improve clinical practice. Fearless neuroscientists that will, in the future, change the way we conduct treatments. I'd like to move to a younger population and focus on child and family development. And I'm going to tell you a little bit about my journey in this talk and what the potential of neuroscience, technology and implementation is for really transforming, and I mean transforming, healthcare. I'm the Michael Crouch Chair in Child and Youth Mental Health. I was appointed to that position about 5 years ago in a very fortunate position. It was donated from philanthropy, and the position was set up to bridge research and practice across the hospital and the university to make sure that science translates into practice. And it's been an absolute privilege to work with many great clinicians and researchers across the university to make effective healthcare advances. But what I want to do first is I'm just going to take, by the way, thank you very much to everyone who's set up this talk. I've never been to a talk with so many people online and in person to a university talk. What a great event you've organised. So I'm just going to ask the question about what promotes change. And this is a question that has to be based on science, and it's a really, really important question, and why neuroscience is so important. You see, if I asked you the question, what promotes change 3 years ago, what I might have said, 300 years ago, not 3 years ago, geez, 300 years ago, I might have said, I need to change the type of blood that goes around your veins. I might need to amputate an arm. I might need to give you a blood transfusion, and that will solve emotional problems. Sounds like a good idea. It was based on possible science. But luckily that theory was proven untrue, and so we no longer chop off arms to improve mental health conditions. What happened in an experience was the scientists injected ink into the blood of animals and noticed that it went to the cortex. That was interesting, and then the focus became on the potentially the brain might solve issues for mental health concerns. If I saw you in the mid-1900s, 1950 or 60 or 70 is what I'm trying to say, the 2000s, what I might have assumed was there was a part of the brain that was responsible for certain behaviours. We had a part of the brain that controlled memory, a part of the brain that controlled attention, and there was a part of the brain that was responsible for anxiety and depression and all our emotional problems. It's very hardwired. We'll find that part of the brain. And a lot of the treatments were very much based on trying to solve the deficits that were part of our brain. What neuroscience has told us over the last 20 years is, in fact, that theory is also wrong, that, as Angela mentioned, the brain has incredible capacity to adapt, to learn, for new pathways to form when we never thought they could, and for people to do things that we never thought were possible. There is no debate. The brain is an incredibly adaptable, incredibly plastic, and learning pathways and circuits that guide that are very, very important. So when I sit down as a clinical psychologist, which I am, which surprises me, here I am, a CBT evangelist, I'm telling you that I'm really interested also in neuroscience because I need to understand how it influences circuits. And that is why neuroscience is so, so important. We need to understand the mechanisms, and I'm going to take you through this talk to show you why. Now I'm going to focus on child development. This video doesn't automatically start. I don't know, hang on, 1 second. No, that doesn't start it. Oh, there's always video problems in talks, isn't there? Well, that was a video. And it was a really cute video. She is the cutest girl ever. And that's my wife. The other girl is also very cute. But anyway, the point being is that, what was I saying? I got distracted by my wife. What I was saying was that not only are circuits really, really important, but there's greater knowledge around what's actually really important. And it's not just circuits, it's not just genetics, but the social environment. And what we mean by the social environment, well, it's not just teaching, it's not just maths, English and arithmetic. No. It's about attachment styles, it's about secure environments, it's about, if you like, the vulnerabilities in our society that leave people at greatest risk and put our brains and our development at greatest risk. So the models that we're developing are now focused on, can we provide the best environments interacting with brain development to support children and support family well-being. And this knowledge we need to translate. Absolutely we need to translate. But it takes time, and at the moment, estimates say that the average university takes 17 years to translate findings into practice. What I've noticed that the University of Washington has, which is very similar to the University of Sydney, is a real focus on speeding up this translation. A real focus on working in clinics, a real focus on making sure that these advances reach the people that need it most. And so what I've been really focused on myself is this idea of what creates an optimal, if you like, circuit for social learning and social development. And what we know is that social play is really, really important, and there are certain behaviours that we think children learn from their environment from more effectively. So when children are engaged, they're relaxed, they're happy, and they're able to go back and forth with their caregivers or their play partners. They're able to learn from the other person, they're able to take on that information. If they point to an object, they're able to focus on that object and learn about that object with that other person. And those behaviours have long been known to be important for social communication. What I'm talking about are things like joint eye gaze and joint attention, the idea that I point and you follow where I point to, and then we talk about the object I'm pointing to, and then you come back to me. It's a really rich social world when you engage in a lot of those behaviours and learn about other people. And there's no doubt that humans in general, and children as well, develop their social cognition and social skills at different rates. And we can almost put this as a really widely used slide by the CDC. We can almost put this social development on a height model of what we expect to see at different ages. And some kids are slower and they're just naturally slower and they'll catch up. But at some point, there is an area where we actually need to provide some supports to make sure that those children get the supports that they need. And I want to focus on what's the diagnosis in the DSM of autism, which is a neurodevelopmental condition where there's a divergence in social development. There's a possible delay where kids just don't engage in the social interaction play, and there's certainly a different way of interacting in the environment. And autism, when I was trained as a psychologist in 2000 around, autism was considered relatively rare, 1 in 150. Yeah? And so I don't think I did any training whatsoever about how to support kids with neurodevelopmental delay, whether it's autism or ADHD or Tourette's, or there was just I did nothing, absolutely nothing. And it was seen as something that wasn't really mainstream. Well, it's pretty mainstream now. It's 1 in 36. We know that 1 in 10 kids will be diagnosed with a neurodevelopmental condition, and we know there's lots and lots of adults that need support with neurodevelopmental conditions that just got missed, never picked up. And that's a real problem because it causes all sorts of other problems. There's flow-on effects. We know there's huge problems in terms of employment, in terms of education, in terms of being able to live people's best lives. They don't get the supports that they need. Now, some of you may have heard of the NDIS. It's an Australian funding scheme. It's a world first funding scheme. It's a really great invention. And it's an insurance scheme for everyone who has a disability. And if you have a disability and you qualify and the qualify is under significant debate about what requires to qualify. You are given supports to participate, that help you to participate and feel included in society. And that support package could range enormously from, say, $10,000 a year up to something like $300,000 or $400,000 a year, based on what the support needs are. It's a wonderful scheme. But there's some big issues, some really big issues for Australia, but it's a really good model to think about how we best support people with developmental and disabilities, if you like. One of those issues is what works. You know, how do we make sure people get supports that actually work? And in fact, the federal disability minister came out yesterday trying to tear up the system to make sure that only interventions and supports that work are funded, because there's a huge waste in spending on that. But most importantly for this talk today, 1 in 35 kids, 1 in 35 people are on the autism spectrum. And this means that if we don't have the right knowledge about what to do, we are spending money on a huge portion of the population where we don't know what they get is beneficial. This has raised a huge social need. We need to address this issue. Now, this is actually data that we've worked on in the hospital, this child development unit. But what we've been able to show is that, you know, to get an assessment, you know, the argument is you need to provide early intervention. Early intervention, early supports help children to, if you like, integrate and to have better educational outcomes. So if they need certain supports in schools, it can be provided. If they need certain supports in the home, it can be provided. Well, unless you're wealthy enough to access a service in a metropolitan area that might be a psychologist or a paediatrician or an occupational therapist, you rely on the public health system in Australia, and this is not unlike many systems across the world, where there are huge wait times. And what we find is that parents notice there's a delay, there's a need for support and intervention at 3 years of age, and they sit there waiting. And we find that they're not getting service until 6.5 years of age. They've been at school for 1.5 years, nothing's happened. Families know there's a problem, and it's not necessarily they need to intervene for the child. They might need to do things in the environment to really support the child at school. Nothing's happening. It's unacceptable. And we find that one of the barriers is our systems for assessment are complicated. They're very good. We have really great systems for assessment in terms of identifying and diagnosing, but they're pretty complicated and hard to sort of train in. And it means that when you've got kids all over, this is New South Wales, you can't quite see it, but in New South Wales, Sydney's like, I can't quite see it, but it's about there, if I'm thinking. Or, you know, how are families in the country regions meant to access support and services? Well, like everywhere in the world, they actually don't. So the wait list for families in these country regions is much greater than if you live in Sydney. Perhaps what challenged us the most was that if you're a family that's been on a wait list for many, many years, and then you get to the clinical service and you get the best, these are the best clinicians. I know a lot of them. They are great clinicians and they do a really good job. But then, our funding support mechanisms, like many places across the world, are focused on the diagnosis. So they'll get some great recommendations around the diagnosis of autism, and caregivers will come with a whole range of other reasons that they want support on, and that obviously won't be prioritised because it's not associated with the funding, and they're missed. We actually found that 60% of kids in these clinical services were reporting for mental health problems on what's called the CBCL, and only 1/3 of those kids that were reporting those clinical levels for anxiety were receiving any recommendations about mental health. It's really quite understandable for clinical service. Anyone that works there knows the load that clinicians are under, but for families it's just not good enough. And there is a real problem with not just accepting the situation as it is. We know that when you do nothing, problems emerge. Real mental health problems turn into, more complex mental health problems. So kids that don't get support, they might become more socially isolated. They might, experience more mental health in terms of we know that kids with neurodevelopmental delays experience much higher rates of depression and anxiety, much higher suicide rates. And then there's a huge cost for acute mental health care. So for example, at least in New South Wales, we looked at every single admission into hospital for a child and what it was for. And people don't realise, but 2/3 of the admissions in hospitals were for mental health concerns. People that couldn't get access to the right treatments in the community, high percentage of neurodevelopmental concerns within the depression and anxiety and eating disorders that was emerging. So when you don't provide treatments, problems become far worse and more chronic and more dangerous. So essentially my role with the team at the University of Sydney was really to try and change some of the systems. And one of the first things we did, I'm going to go into 3 phases of my talk. The first phase is looking at how we integrated our assessments and technology into clinical services in partnership with our clinical services and really the difference that it makes. The second phase is to look at some of the markers and the way that neuroscience can inform how we're studying whether people respond to treatments. And the third phase is to look at some of the outcome measures and really how we might change a system. But one of the things that really struck me with clinical services is I went to many of the hospital services and tertiary services and community clinics, and I'd say, how's Johnny going? And tell me a bit about Johnny in terms of what he did in this assessment. They go, well, this is sort of the outcome that happened. And he actually came a couple of years ago and he's come back a second time. And I've gone, well, why did Johnny come back a second time? Oh, we don't know. The files are archived somewhere. But anyway, he's here now. We're dealing with it now. Well, what's changed in the last years? Well, we don't know, actually. Right. The way data is used in a lot of our clinical services is for a clinical purpose, but it isn't necessarily optimised to provide the best experience to understand what's happening to people over time. So we decided to change that and to create electronic data collection methods for the hospital to use as a part of research. And so what we did is when anyone came to the hospital or to the tertiary service, we partnered with the lead clinicians, and in particular Natalie Silov, the head of the Child Development Unit, really started it with me, to really try to ask families if they participate in our research and allow us to collect their clinical information electronically. And so what we did is we sent out all the information, instead of pencil and paper tests, everything the clinic did was electronic. And families got questionnaires, and what they found is that when they sent out the questionnaires to families before turning up for assessment, the response rate went up from 40% with pencil and paper to 90% with our electronic methods. So that meant it saved huge amounts of time for the clinician because all the questionnaires could be scored and ready for report writing. When we asked families what they preferred, most of the families went, I much prefer this electronic data collection. It's so much easier to complete on whatever device and when I'm ready to use it rather than a thing I have to post back. And clinicians were reporting they had much more time to do other things in the assessment. So this provided a really good sort of summary this is on 900 families, that actually electronic data collection methods were working really well in these clinics, and we could harness data collection for research. In fact, we have a really low, maybe 2% of families that say they don't want to do the research. It also allowed us, and we did this nationally across Australia, to start going, well, given that the focus is on diagnosis, understandably, that's where the funding is, we want to make sure that nothing else gets missed. Like what the other things that really matter, that we need to collect information, and we want to start to integrate that information. So we went across the country and we surveyed clinics and looked, and it wasn't just autism, it was also ADHD and cerebral palsy and Tourette syndrome and a whole range of other clinics that supported rare genetic disorders as well. And we decided on a set of, if you like, protocols that were going to be standardised across all the clinics to collect information that would otherwise be missed, partly for research, but really to try and get a better read on what's happening for families and kids around their health and well-being. And of course we use these electronic systems where we send stuff out to families with standardised, but most importantly, and this is the part, I can tell you this is 5 years of work what I'm going through. I know you don't appreciate it, it sounds very simple, but doing implementation work is super, super hard. And as we started getting automated reports coming through and clinicians saying, oh wow, this is actually saving time because I'm getting not only, I mean they're starting to use styluses now and with everything they're inputting in is going into automated scoring, this is really helping families. And you're going, yeah, it kind of is. And clinicians have been so wonderful, and when we give these reports, it saves them time and it makes them able to then personalise those reports to make sure that families and kids get the information they need for them. And so what started as a wonderful collaboration with Natalie at the Children's Hospital at Westmead, integrating in digital tools, has really expanded. We've got local health districts all across Sydney wanting to access and use and participate in our research program to improve outcomes for families. And so we're now looking at how we can expand this across local health districts. And the aim really longer term is to go at country as well. Most importantly for our research, it's giving us a huge database to give families access to the best treatments, the best research, and most importantly, this is what I love about this database, they're the families that often miss out. You know, if you put an advert in a university clinic, go come and participate in this trial, you get a family that probably isn't the same as the ones attending these clinics. These are 50% from culturally and linguistically diverse, largely very poor, 5% Indigenous, and it's 2,000 a year that are coming through, and we're starting to understand their needs. And it really provides us an opportunity to advocate. So in real time, in this almost a living laboratory, we can start to advocate on the needs of groups as they're coming through in different groups. So this is just a very brief example. This is of data just right now. I can tell you now that of the services that everyone in the clinic can access, the services they can't, they really want behaviour therapists and psychology services and OT. And I can also say there are barriers to getting care are things like wait lists, financial proportion and lack of knowledge. And this is both interesting from an advocacy point of view and a research point of view about how to change systems. But it's also really, really important from a clinic service point of view, and so we're working really closely with our clinics. And so finally, I've got in this implementation component, Dr. Boulton is a lead postdoc in our team, and she's been developing digital tools so that families, when a need is identified, that need can be immediately met, at least partially, with a digital tool rather than waiting for services for too long. And we're hoping to really build out these digital tools across our network. But I'm going to get into the neuroscience now, because the question really is, what works? And if technology was going to solve everything, well, the iPhone would have fixed everything, wouldn't it, in 2007? But it didn't. It created some problems as well, actually. And the problem is that what actually is needed is an understanding of what's needed to change, the circuits that change, the mental health that needs to change, the treatments that work, so that we can make sure people get it. It's pretty simple. And we did a review in 2017, and we looked at all the trials that had used a dietary supplement or a medication for autism in children, and looked at whether how many trials had been conducted. It doesn't necessarily have to target a certain feature. It could have been irritability or something else. And at the time, we found 3 trials existed with really good inclusion criteria, really well characterised randomised controlled trials. 3 trials existed with more than 100 kids. There were about 37 in total that were really well designed. There's been a lot more in the last 5 years. But can you imagine if we were talking about depression and I said to you, the randomised control evidence, there's 3 trials of 100 with 100 children or more in it. That's half a book on the shelf. Half a book. Really unacceptable. So what are we supposed to do? There's all these, in the autism world, I'm not sure if you know, but the world is tearing itself apart. I'm getting told all the time that we're crucifying kids in this way and we're saving kids in another. There's so many really strong polarising opinions. What we need is science to save us so that we can provide scientific-based answers. And we're doing lots of different therapies, there's lots of psychological therapies here. I'm talking about the neuroscience, lots of really good neuroscience-based therapies we're trialling. And I'm going to talk about oxytocin today. Why? Well, because I could talk about these other things, and we're not doing MDMA in kids, by the way, that would be entirely inappropriate, but we're doing that in adults. So, point being is, these things are relatively new, there's still a bit of hype. What happens is that when you've got a new, cannabidiol, it's going to save the world, it's going to be good for this, it's going to be good for that, it's going to be good for everything. That happens in every therapeutic, right? And these therapeutics are in that space right now. But what happens is, they never deliver on the full promise, they deliver on some of the promise sometimes. Ketamine's a good example, and TMS is a good example of delivering on some of it. But the question is, are we able to persist with the science to understand the circuits, to understand what changes, and to make a difference? And the answer is usually not. Usually once the hype is gone, everyone goes, oh, it didn't cure the world. The funding goes with it, and it's very hard to understand whether things work. So I'm going to focus on oxytocin because it's gone through that. Now, as Angela so wonderfully presented on, oxytocin is a natural hormone and neuropeptide. I won't go through what she said again, other than to say, in 2006, which happens to be 17 years ago, I started doing oxytocin studies nasally, and we found that oxytocin did things like increase eye gaze, almost double the amount of eye gaze when people looked at faces. It changed the way people processed faces and improved memory for social information. I thought science was so easy. I was getting high impact publication after high impact publication because oxytocin was seeming to do all these wonderful things, and people were starting to get really excited about it. It was like, you know, papers coming out calling the love drug the cure for everything in the DSM. It was very, very, very exciting. The reality is I was never going to do all that, and Lynn Sikic published a trial last year in New England Journal of Medicine, or it was the year before that maybe, to show us that it wasn't working at a population-based level. But what I wanted to do is really go through the rationale and the neuroscience that's going to help save this story. So what happens is there's some great researchers, Larry Young, Karen Parker, Sarah Freeman, they're all doing these wonderful prairie vole studies where they inject oxytocin into the brain in animals, usually the nucleus accumbens or something cool like that, and then they show that oxytocin is then released and it releases dopamine from D2 receptors, and that results in bonding. And all of a sudden, these little prairie voles, they find a mate for life, their life partner, just from getting a bit of oxytocin in the brain. It's really wonderful. Repeated, replicated over and over again, lots of really good studies. Yeah? Really close on circuits, like we know that this molecule is really important for social recognition, important for bonding. So what we're going to do is we're going to have a look at and see what happens in humans. And so what happens is I get a nasal bottle and I spray it up the nose, ready for action. And what happens is we get lots of mixed results. And we're like, oh, I wonder why it didn't really work. What happens to my D2 receptors in the nucleus accumbens? Isn't it supposed to do something? And we have these human models that explain to us, really, this is my circuit model, so I'm promoting it. But it's really about how we think kids learn and process social information and sort of respond. And we just think oxytocin is going to come along and fix all that. And so it shouldn't be surprising that in our studies we've shown some benefit, but it's all really, really mixed. And it seems to be, for what we're showing, is that kids when they're younger, they seem to show greater social responsiveness under oxytocin. And as they get older, the effect seems to wane away. So we often see some kids responding. The little red squares on the right indicate a response under oxytocin in both things, and it seems to be really promising. But then we've got to look to the mechanisms, and we think, well, it's got to be more complicated, and again, neuroscience comes into it. So I was sitting at a conference, gloating to myself about how wonderful my presentation was. And then a vice president of a pharmaceutical company comes up to me and he says, Adam, by the way, how much time have I got? Sorry, don't worry about it, I'll keep going. So anyway, the vice president says to me, Adam, a great talk, but the nasal spray delivery is a lot more complicated. I said, what do you mean? He goes, well, and he opens up his little laptop. I go, oh, wow. And he says, hey, this is what pharmaceutical companies know about nasal sprays. And he showed me that the nasal structure is really important, that the environment of the nasal cavity is really important, that the plume angle, the way the nasal results in the delivery of drug in the nose can determine whether a nasal drug will be absorbed into the brain or body. And then he was like, it doesn't just go into the brain. We don't know that it just goes into the brain. It could go peripherally into the body. And so we developed these. I was like, wow. And it was like a half an hour discussion. He goes, that's enough now. I said, well, how can I get hold of that information? And he was like, well, this is industry information, it's protected. It's like, oh, geez. It changed my life, because then we got a huge team of wonderful students, because if you know me, I'm not going to study pharmacology. A huge number of students that did different aspects of trying to look at how nasal sprays were absorbed. And we sort of came up with some recommendations about the mechanisms of nasal delivery. We still need to know how it's absorbed into the brain and body. And we've recently developed a radio tracer to study where it goes. And the radio tracer is almost exactly like oxytocin, but it just has one part that's been, if you like, modified, so that it's got like a highlighter on it. So when we put it in the scanner, we can see where it goes by modifying it. And then the radio tracer, when we deliver it to animals in a whole range of studies, we've found that it does exactly the same thing as oxytocin. So we're pretty confident that this is just like oxytocin. And then when we've done some really cool PET studies, trying to see where it goes, we find that, well, it seems to congregate around the pituitary gland and the mammary glands. That's exactly where we expect oxytocin to be, and also in the gut, because that's where nasal sprays go when you get them. So we're getting really good data suggesting that our radio tracer is telling us in animals where it goes and what parts light up. And this is a really important part of neuroscience. We got one unexpected finding. I said, this unexpected, what is this about? And what it was we kept getting these results around the skin. I'm not saying that it's more complicated than oxytocin and skin stuff, but I'm going to say the skin broadly because I don't want to get into those details. It's like, why are we getting effects on the skin? What's the skin got to do with anything? And I was like, okay, well, I'm going to review the literature on the skin. And then I had an honours student, just one of a really hard-working honours student. And what she did is, I said to her, look, a really high-risk project, but I think we need to understand the interaction between the brain and the skin. And so she did this wonderful review looking at the skin and the brain. And as it turned out, I'm probably the only neuroscientist that didn't know this. But the brain and the skin form in the ectoderm in the first weeks of pregnancy, and then they separate. But when they separate, they experience the same genetic and environmental impacts, and they both develop, if you like, structure. So the brain develops what we call cortical structure, and the skin develops skin barrier integrity. I thought, wow, that's really cool. And so it's very likely, I went, well, maybe the skin and the brain actually develop together, and in the first weeks of life we might have a simple test to detect skin barrier integrity, which might reflect cortical integrity. So what we did is I went and spent a lot of money on a tool test, which is just an infrared light. You put on your skin. Companies use it all the time to look at their their skincare products. And it's just a quick buzz, and we get a skin barrier integrity rating, which is a rating for water loss. And the initial data was shown, which I can't present today, but it shows that autistic children versus children that do not have autism, there's a difference in their skin barrier integrity, and children on the spectrum seem to have lower skin barrier integrity. That's not particularly exciting because there's lots of other reasons why that could be the case. We're now doing a study on babies, looking at how in the NICU versus not NICU, whether we're getting skin barrier integrity early in life that's different in the NICU babies. Now, why am I saying this? Well, because what I'm trying to highlight to you is that neuroscience has put me in a completely different direction, and I'm not saying this could be complete rubbish, but it could lead to a very simple test that could tell us something really important about child development. And that's what I love about neuroscience, and that's where I came, how I got into also the oxytocin work. So the next part of my talk now is starting to look at markers. So we know that oxytocin, we think it's beneficial for some, but certainly not for everyone. We don't know why. We have a whole range of markers we're looking at, trying to pull apart circuits to see how things change. Marilena's done a lot of work on spectroscopy and baseline fMRI. But I really now want to focus on joint attention and the initial start of my talk, which is the way that people interact with each other with their eyes and the way that they move. And if my heart races, I hope your heart races at the same time too. It's that idea of being in synchrony with each other. And whether that we could develop markers for that tap into the circuits that we think oxytocin and to some degree social interventions might influence. And then I go to the eye tracking literature, and the eye tracking literature, it's wonderful. It's really mechanistic. It tells us beautiful reasons as to why people aren't looking at certain pictures. But one of the problems with it is that there's a lot of changes you get in results based on small changes to paradigms that becomes really confusing. The typical sort of task is to show social and non-social objects, and then to see that children that may, or adults that may struggle with social interaction pay more attention to the non-social objects. It gets a lot more complicated than that, and I don't want to get into the debate here. But what I will say is the translation of these sorts of tasks into practice is very, very poor. So these tasks don't seem to be very good at predicting outcomes. And so what we thought was, well, maybe it's because these tasks aren't reflective of what goes on in the home. And so we thought, it's a bit of a left brain idea, but we thought we would try and mimic something that happens in the home all the time, which is like a shared book reading task, and to see how kids responded to shared book reading. So, whoops, the video there is also not working. There was a lovely book reading task and she's pointing to parts in the book and it closes in. We spent a lot of time, that's an actor, paid actor too, can I add. But the point being is we're trying to get the child engaged in the book and to track their movements during the book reading. Oh, no, it is moving now. There we are. Oh, but there's no sound. I did need sound on this one. Okay. But you can get I think you can get the idea. We tried to model it on, we've got Play School in Australia. I don't know, you might have, I suppose they do this in Sesame Street. No, they don't do it in Sesame, anyway, whatever. So, and then what we do is we sort of isolate areas of interest to try and figure out where kids are looking during the book reading task. And we're hoping to see that they're looking where the actor is pointing, the face, and also the objects that are of interest. And we typically would not want them to be looking at these distractor objects in the background. And so we can track the eye movements. These are examples of eye movements that we want to see in terms of responding to the information, and these are ones that are a bit distracted doing something else. And as we'd expect, this is Ahava Mbachi, who's a PhD student in our team. She's shown that, and this sort of replicates a lot of the work, the complicated work in the literature, that when people look at when kids on the spectrum are given social tasks, they probably pay less attention to the social information than non-autistic kids, and they probably get more distracted with the background objects. And so we've replicated that effect, which was quite nice. But most importantly, there are two things that came out. We then got the kids to play with an experimenter in the real sort of testing environment using the ADOS, and we counted the amount of eye-gaze interactions, and we then also looked at ADOS social severity scores and verbal and non-verbal skills, and we found this task, the amount of social, if you like, interaction and dwell time on the right features significantly correlated with all of those things, which was really exciting because it's showing some translation ability of the task into outcomes. Now, the point of this is not to show you this task actually. The point of this is to get you to start to consider technology, neuroscience. We have so much we can develop, and I think that if you can mimic what you're trying to develop in the real world, you're going to get tasks that better map onto and better predict real world outcomes. That's my prediction, and I wonder if we're using technology enough or whether we're staying with old paradigms because they're mechanistically very precise that may not necessarily predict outcomes. And it's a question, it's not an answer. The final thing that I'm going to talk about is outcome measures. One of the things in our trials, what happens is we do a trial and we say, okay, well, let's talk about social outcomes. The clinical assessor will rate on a 3-point scale whether they've observed eye-to-eye gaze and social interaction, and then they'll score their 3 points up to get to 9 points. And then on the SRS, we'll ask parents to rate whether they think their child has been engaged in the last couple of weeks. And I'm being a bit facetious. But these are really, really great tasks. These are really thorough, really well developed. They're brilliant at differentiating between kids with social skills and kids that might need support. They're great. But they're not very good as markers of response in clinical trials. So we also went, well, what can we use with technology to try to change that? And so there's actually lots of really great and free algorithms you can download to videos to try and start to analyse videos to get sort of objective data. So this is just showing some of the data that we've analysed using kinetics, just movement, body movements. But most importantly, you can just download algorithms to look at facial expressions and whether people are smiling. But my PhD student, mine and Alistair's, who's a wonderful engineer, what they have done is, with us, is identified algorithms that can quickly calculate things like eye gaze and joint attention, and other features which I can't talk about. But what I can say is when we put all those things together, we get really reliable differentiation between autism and control. So what this is saying is that that's much higher actually than clinical measures at the moment. So what I'm saying to you is that we have potential. I can order currently my dinner, not my dinner, but I'm sure someone's got a fridge here that can order their dinner. I hear that's possible, and the fridge will tell me what I need to order in my dinner because it can read what's in my fridge and what I don't have. That's what I hear about these amazing fridges. But we're still using, very wonderful but outdated assessment measures for health. And I think technology, not on its own, but in combination with neuroscience, with precise markers, can help us to make a massive difference. And now I'm just going to tell you briefly, we've got a trial at the moment where we're looking at social learning therapies. We're trying to look at kids that are engaged in social learning treatments, if you like. We're giving oxytocin and without oxytocin to see if it helps them to learn that information more quickly, and we're looking at objective markers, and that's a collaboration with Sally Rogers and Geraldine Dawson and Cheryl Disanyaka, and we've incorporated a lot of those personalised medicine markers that I've talked about. So at the end, but finally, I just wanted to say that the most important part of our work is that it is embedded in hospitals and in clinical services. It's going to expand across New South Wales, and that we are providing what I'd like to think as the best research to the families that receive the less services, at least in New South Wales, and I think that's the opportunity. Okay. Finally, I'm just going to say that, I've talked about neuroscience, importance of understanding circuits. I've talked about technology and the potential that technology has if we use it right to be precise with the right circuit, not to give me a dodgy app that makes me addicted to games. And I've also talked about the importance of implementation science. But all these three things I don't think on their own will change health. I think what we actually need, and what has worked over the last 5 years has been leadership to share a vision and to believe in that vision. It's really hard work what we're doing. Collaboration and partnership. You can see from this work I'm leading almost none of it. Friendship, trust, clinical services, researchers working together, believing that they can create a change together in friendship. Persistence, there has been more, this story has been, I can't tell you how many times I've hit my head up against a brick wall and almost cried. And most importantly, of course I've got to end on this, it really needs good science. So thank you. And also just thank you to there's a huge team. This is my immediate team, but the clinical leaders in that team, Natalie Silov and Antoinette Hodge, and then the wonderful postdocs I have in the team that really do the work that I can talk to you about today. Thank you.
Okay. Should we do some questions?
Oh, whatever you like.
Yeah, because
I don't.
I know. Hello, can you hear me? Okay. And so what we'll do, now you see Angela's back, and I want to thank Adam for such a wonderful talk. There's so many questions and so many facets to what you've been doing. Again, congratulations for getting as far as you've gotten too.
Yeah.
I know, like Nikki said, it's not easy.
Yeah.
But I guess I just want to open it up for either questions or comments from the audience for either Dr. Fang or Dr. Guastella. Oh, okay. Not sure where she went. And then, so if you want, if you can talk loud enough, you can do that. And we also have microphones right here. There's also one over there if you want to make a comment or have a question. So I guess, I don't know if Angela can hear, but also maybe this is related to you. So you have these methods of using neuroscience and so to help you to understand what's going on. And in one case, like in Angela's case, she's saying that, oh, well, you can maybe use neuroscience to just predict who's going to be responsive, who's not going to be responsive,
Angela?
and so on, right? And so then does that mean that it would be possible that if you found somebody, for example, or some of the high risk of maybe being a non-responder, that you can engage and then develop new sort of behavioral therapies to strengthen their ability to respond once they might encounter an issue? Or
Yeah, I think that, Angela, did you want to answer that question? Can you hear us?
I don't know if you heard me, Angela.
Can you hear us? I'll just.
Okay, yeah.
Angela would say, most definitely you can. And what can you? What? Oh no.
We can't hear you.
You've got to join the audio. Yeah.
Oh, no, can you hear me?
Can you hear us okay?
Yes, I can hear you.
Oh, okay.
I just missed the question.
Your question.
Okay, so this is really for both of you. And I just love that how you're using neuroscience and other technologies and so on to help you with not only sort of predicting, for example, who's going to be responder and who's not going to be responder, and you know what kind of brain systems might be responsible for one or the other. And so is it possible to take somebody or identify somebody who might be a high risk of being a non-responder and then maybe start some sort of preventative, you might say, treatment, cognitive exercise or something that allows them to go between these systems in a more resilient way so that when they encounter stress, maybe they can respond better?
Exactly, yes. Yeah, I would say that's exactly the thinking, is to rely on other types of interventions that are available that can be used to shore up additional resources they might need in order to engage fully in CBT, or there's available. I think the cognitive remediation literature is a good example of this, where there's certain cognitive skills that they try to improve in patients before engaging in something else. So I think, yeah, exactly. Brain imaging has the potential to identify what those maybe deficits are in order to shore up their resources for future therapy.
I don't know if you had something else you started to say.
I think that there's lots of, this is all about trying to get the right treatments to the right people, and we know that dosing is really important. And some people, so if we can identify, which I think we can, the non-responders, it's really about getting them the right treatment, and if you like a step care model where you're doing more significant treatments for those that need it.
Yeah, there's a question over there.
So you can hear me. So I'd like to just make a statement that it seems as though the fMRI machines and those types of studies would be very difficult for the average citizen to access. And getting authorization for that would be so difficult. However, it seems as though putting that together with the other testing and medications could prove really valuable for the future. So keep trying, keep going. But then my other question is that the oxytocin theory seems so valuable, but it kind of reminds me of TSH levels, right? Like, so do they perhaps just not have, maybe the receptor sites are loaded with something else and that they can't receive the oxytocin, they can't use the oxytocin? Why would they produce more oxytocin in response to stimuli, right? Like, so why would they have too much? They just must not be using it, or the receptors aren't there or something. That's all. Thank you.
Thank you. What I would say is that we're reasonably confident. It's not like, we have to be very careful with sort of magic ideas that we give oxytocin and then, if they don't have enough of it, then they're not social enough, or they're not, they're too shy, or it's not that one-on-one mapping. Oxytocin, when it's released in the body, influences a circuit. That circuit's complicated. It has, it's about salience, it's about reward, and we can pull apart those mechanisms really well. And I think it really is about a combination of factors that influence the response. But we can map that response. That's what's beautiful about this personalised medicine that we're doing. And I think that the real danger is that going back to the start, that when people want that really simple answer and they don't get it, they give up. And people will give up about the other treatments as well if that's what they want. Going back to your fMRI thing, it really is about demonstrating value. As Angela said, if fMRI adds that much value, then it's going to save a lot of money to government. So it's about demonstrating that.
If it's possible to add to that too, I would also just say that let's think about the cost. Can you hear me?
Yeah, now we can hear you better.
Okay, I'm sorry. Tonight has been such a comedy of errors. Thank you for putting up with me. I was on the last slide. But so I would also just add to that there's billions of dollars spent per year on treatments that we don't know if they're going to work for somebody. And so the cost effectiveness of fMRI, even though it is an inaccessible technology right now, I would think about just the value potentially gained if we were to integrate it into routine practice. It's already reimbursable by insurance for pre-surgical planning, for epilepsy. There's a precedent for it. It's not ready yet for psychiatric disorders because there's still measurement issues of standardization and reliability. But I really think it's adding more valuable information that we otherwise would not have access to.
Great. I also want to thank our Zoom audience, and I think there's a question coming from our Zoom audience.
Yeah, there's two questions, one for each of you from our Zoom audience. So we'll start with you, Angela. What are your thoughts on using psychedelics as an alternative treatment option for some mental health disorders, specifically the interaction effects on the 5-HT2A and glutamate receptors?
I think psychedelics are really hot right now, and I think Adam was pointing to this in his talk too, that sometimes some of the science, you have to manage public perceptions, and I think there's an ethical responsibility we have there too to manage people's expectations about the brain findings. The best I understand from the psychedelic literature is that the theory is it's impacting some brain plasticity, but I think that's a very broad mechanism. There's a lot of things that impact plasticity, and I think that science is still just emerging. That's not to say that it doesn't completely change people's lives, but placebo can also do that. So there's a lot of things that explain treatment outcome, and I think there's just little understanding still of what the mechanism really is. As far as the serotonin and glutamate, I would say it would be hard to imagine that psychiatric disorders are not implicating those neurotransmitter systems. Same with dopamine. I think serotonin and glutamate have been better studied, at least for the anxiety disorders area, depression. But I hope that at least is my 2 cents on that.
Yeah, thank you so much. Our next question from the live stream audience is for you, Adam. Does skin-brain antenatal link last through life? If so, is this a reason physical contact during development is so important? And could the skin be implemented in therapies later in life?
I'm sorry, I couldn't understand. I'm sorry.
Just go ahead and read it again.
Does skin-brain antenatal link last through life? If so, is this a reason physical contact during development is so important?
Yeah.
And could the skin be implemented in therapies later in life?
Yeah, so thank you. That's a really smart question, and I'm sorry, you think my accent's hard to notice. Everyone teases me about my accent. No, I think the issue around skin barrier integrity, there's a long literature in sort of diseases of the skin, atopic conditions that look at skin barrier integrity, and also in babies with. And so what we know is that in the first days, there's a few days when the babies are first born where skin barrier integrity really is sort of stabilised. And then there's a real debate about whether you can improve it through skin treatments early in life. And then there's other literature that suggests that it is stable across the lifespan. But then I get confused because then there's, if there are people in hot rooms they're exposed to different types, and then the rating changes. So it's hard to figure out, what is your base level. I mean, it's an area that I'm just learning in, and as a neuroscientist, I've got a lot to learn. So, but my understanding is, generally speaking, after the first few weeks of life, it stays relatively stable. Yeah.
I guess can you guys hear me? Cool. I'm a mental health therapist, and I do a lot of exposure therapy. And it was super cool to learn more about like the dorsal brain system and the default system and how it might be switching back and forth. Because that's something I never learned. I'm a master's level clinician, and we never had any sort of neuroscience classes. And I'm just curious if what you tend to explain, like when you're doing psychoed on anxiety, if that's something you typically explain to someone about the neuroscience that's going on. And if you have time, I'd love to hear like your little spiel that you might give them, or if you can point me to like a video of someone doing that, that would be really helpful for me and my clients.
Absolutely. Yeah, we have a whole curated list of those resources. So if you email me, you would have seen it on my last slide if I stuck around to do that. But if you just email me, I'm the only Fang at uw.edu. Yeah, I think you would talk about that. We train our students in the training clinic all the time to integrate information about neuroscience. We don't talk about the dorsal attention network and the default mode network quite as much, because that's more a network system that we've identified related to self-focused attention. But when it comes to extinction learning, when it comes to psychoed, just about how malleable our brains are and the patterns that we see change after CBT, we definitely talk about those things.
Thanks. I'll email you and get that info. Thanks.
Okay, well, one more question back over there.
Hi, thank you. I work in primary care as a psychologist, and you guys were mentioning gut therapy related treatments as well. And in primary care, we see so many people with these multiple comorbidities and intersectionalities there. Naturopath is huge here in Seattle with Bastyr University as well. Autism, there's a lot of trials around, don't eat gluten. So there's all kinds of nutritional interventions, people with mental health and social determinants of health issues have poor nutrition, et cetera. So I'm curious to hear you guys comment both in terms of the science of what do we know if we're trying to cure the brain, but we're not dealing with the gut and the nutrition around that piece, and then also thoughts you have about integrating our health system more so where we can tackle whole person care really from all these different angles.
Yep. Do you want to go first, Angela, or shall I?
You go first.
Okay. That question is such a beautiful, beautiful question, because it really does highlight the benefits of the science. We need to understand what's going on, in a whole system that social factors, the social determinants of health. I was trying to find the word in my presentation, and I forgot it, so I made up other stuff. But the social determinants of health really are impacting development, whether nutrition is a huge part of that. And so when we're thinking about changing circuits and changing health and well-being, that is a real consideration. The gut science side of it, around the autism side, well, firstly, there are a lot of, it's early days, there are a lot of interesting ideas. The gluten stuff in the autism space, if that's what you're referring to, it's really mixed, and there's not a lot of good recommendations around. There might be some short-term gain, but there's not a lot of evidence for longer-term gain. We've been involved in a worldwide clinical trial that's looking at a new gut therapeutic, it's we're in the randomisation of that gut therapeutic at the moment. But the open label trial was pretty surprised me. I was pretty sceptical, to be honest, about it, and I think that and it's targeting irritability. So I think that it's early days. It's like me talking about the question about MDMA earlier. It's very hard to give you solid answers, because we need ultimately the science to direct the recommendation. The science isn't there yet. But aside from that, the nutrition and social determinants of health, there's lots of actually emerging studies right now demonstrating how important nutrition is to emotional and social well-being. So I think they're really important factors.
I don't have much to add. I don't know really anything about gut health, except that I do see it clinically that some patients also experience anxiety in their gut. And so I would imagine that there's some brain-body, connections there. But I would just add that what I loved about your question is the role of primary care in delivering mental health education and treatment as well. And I think UW is just so well positioned to look at that, just given the dense network of neighborhood clinics and UW Medicine. And there's just such rich information there that I think can disseminate this work. So yeah, I would just, that's all I would just add is the important role of primary care here and getting them accurate information and yeah.
Thank you. I had research for family medicine here at UW. We met when you first came, Dr. Fang. So I think, this is Carrie Stevens. So I think it would be great to, yeah, you can't see me.
I can't see you. I'm sorry.
Yeah, it's great to see you. And you're very, very big here in Kane Hall on the big screen and look amazing. So I think there is this big connection too, just in terms of the science around serotonin that's created in the gut, et cetera, right? So this brain-gut connection that very few people really sort of realize, and how do different medicines or different nutritional supplements, et cetera, help the gut work more functionally when we've got a lot of patients who are suffering in these ways, who have had long years of, IBS that's, co-diagnosed, et cetera, that are all tied together, really, again, like thinking about that whole person care. So I often think our specialties don't do people justice, right? Because we're sitting here thinking, well, let's do talk therapy over here, and let's do medications over there, and let's, oh yeah, go over to the nutritionist there, but only if you're overweight or underweight, So I just think I love what you guys are talking about in terms of spirited, multidisciplinary teams. So thank you.
Yes.
I've been told I have a question, so I'll just try it from here.
I can hear you.
Oh, you're going to run to get me. It's a quick question to you, Adam. You put up a slide early on the rapid rise in diagnoses of kids with autism spectrum disorders. Can you help us understand that rapid rise? Is it better diagnostics? Is it just a fad, et cetera? How do you explain that?
Yeah, so that's a really important question and something that has been the source of really crazy debates. It's been out of hand, actually. When I was training in 2000, I had my first client as a clinical psychologist was a child with autism. And I saw them, and I feel bad about it to this day, because I was like, that child doesn't have autism, what's going on here? And I had no idea really what I was looking for and what needed support. I just didn't have the slightest back then. And I think that was happening all the time across different jurisdictions, that people were just not being picked up. And so there's been a huge awareness campaign, a lot more training in clinical services. The DSM criteria has become a lot more prominent for people. So I think that, in the American data, what we started to see actually was the states that had all those screening and awareness supports and the clinical services to provide support, they were having much greater increases in the rates of autism. And the states that didn't have those supports in place, the rate of autism was staying the same or not increasing at the same rate. And so there's no question that awareness and sort of diagnostic skill in terms of detection is the major player for those increased rates. I've heard lots of really crazy statements around all sorts of things that are increasing, other things. I haven't seen anything credible that suggests that there's anything else that's leading to those. I'm not saying there isn't, but I think that and the study came out today, I think, in JAMA, suggesting it was just diagnostic awareness, and that's what my gut tells me as well.
Okay.
Thank you so much for your...
Sorry, what I will add to that, is that, I just realised one thing to add, Sherry.
No.
And it's important to that question, and that is, what's really amazing now is we are also diagnosing a lot of people in adults who come in with their kids, and it's because they got missed in the system. So actually the diagnostic rate in adults has started to increase because the kids are being diagnosed, and that just speaks to the, and then when we talk to those adults, they talk about a long history of issues that just not, in terms of needing support, that never got picked up on. Thanks, Sherry.
Thank you so much. Again, if you want to join me with the final round of thank yous to both Dr. Fang and Dr. Guastella. I think clearly with all the questions, there's based on the questions, there's clearly so many interesting questions. I still have a few I'm going to follow up just separately right now.
Yeah.
But again, thank you so much. And thank you, Angela.
And thanks to everyone online as well as
Absolutely.
many Australians, I think, that joined, so thank you.
Oh, well, especially. No, thank you, and thank you for all your questions.